We have already formed a quorum and it's the appointed time. First of all, let us thank the 17 deputations and the administration team for joining us in our discussion. Today we are here to discuss the issue of financial assistance for medical and health or rehabilitation appliances. Earlier on, we discussed the arrangement for the standard drug formula and also the Samaritan Funds assistance. Well, there are many who are chronically ill or disabled who might need medications and medical or rehabilitation appliances. Number one, as the standard drug formula might not cover them. That's why such expenses could be very high. That's why the administration has been saying that it has this safety net, which is the Samaritan Fund, but then is plagued with loopholes and so on. And in terms of calculating the household income, many families are faced with difficulties. So we have a dozen or so deputations, also concerned parties, who would like to express their difficulties to us and would like to discuss with the administration as to how improvements can be made. The administration has submitted a paper. I've read the paper. Basically, there is nothing new in the paper. So if you don't mind, then I'd actually like to invite the deputations to speak first, and then the administration can give its response in one go by responding to their questions and also giving us its stance. I'd just like to remind the deputations that your remarks will not be covered by the Legislative Powers and Privileges Ordinance. In other words, you will have to be responsible for your remarks. Each deputation will be given 3 minutes, so please make good use of your 3 minutes to finish your statement. First of all, we have Mr. Lee, the Association of Parents of the Severely Mentally Handicapped. Thank you, Chairman. Most of these severely mentally handicapped have multiple illnesses and problems. Many households and families are therefore plagued with financial difficulties. After deducting the necessary expenses, very often they could become middle class living in poverty. But then, given the Samaritan Fund and also other assistance that is available, they have not been able to really help them. First of all, on disability allowance. The purpose of having the disability allowance is to help the disabled to meet their necessary expenses arising from their disability. But then for people or students living in residential care homes, the allowance will be deducted by half. And also for the CCF, they would not be eligible right away. And every year, for the time that they spend in the boarding school, they would not be able to get any allowance, and if they have to suspend their classes, they would only be able to get $180 every time. Does that mean that while they suspend school, they do not have to meet any expenses at all? And also, in terms of eligibility, the household's income would be counted as a whole, and therefore, well, of course, but then as a result of that, their siblings' income would also be subject to the means test, and as a result, most of the disabled families would not be eligible. And if they go into residential care homes, they would also be able to get comprehensive assistance. But then you would be splitting the families, and as a result, they are actually living in dilemma. That's why we have this suggestion. That is, number one, we should have a high or higher disability allowance in order to ease their pressure. And also during long holidays, they should also be given a double payment so that that would also help meet their expenses. And also CCF's eligibility criteria should be relaxed so that they would also be eligible. And also for disabled persons living with their family, they could also apply for financial assistance on their own so that their rights can be respected. Thank you. Next, we have Ms. Chen Yin from the Hong Kong Parkinson Disease Association. Chairman, I'd like to say that many Parkinson's disease sufferers are pretty young these days, but then they would not be able to get any allowance under the current system. And also for the medication available under the standard drug formula, not every hospital has got those medication available, and they would also not be able to go to another public hospital to seek consultation and medication, because they do have this clustering arrangement, and many patients will have to go to the private sector, and very often for each medication they will have to pay up to $2,000 for that. So because of the different practices in different clusters, Parkinson's disease patients might suffer. And if you have actual cases, please do let us know, because that has there is a discrepancy under the existing policy. Next, we have Mr. Wong Man Lip, Alliance of Ex-Mentally Ill of Hong Kong. My name is Philip. I am the executive member chairman of the Alliance, and I'd like to share my experience with you with regard to the ex-mentally ill. There are new arrangements and old arrangements. Well, there is another executive member. He has been suffering from this disease for over 20 years, and every day he will have to take medication 3 times a day and about 5 tablets each time. Well, he's well equipped to work, but then he could be very moody, and sometimes he could doze off at meetings, and he's also not able to sustain for a very long time, and every time he will have to take 3 tablets, and I can see that his mood has stabilized, and his performance has also been praised by his supervisor, and at meetings he would also not doze off, and his ability to speak has also improved. I believe that that's because of the new drug. Another example is myself. Yes, I've been consulting my psychiatrist, and I've also given him feedback about the new medication, but then he said that I've been on the old drugs for more than 30 years. That's why he would not recommend using the new psychotropic drugs that are available. And because that would take some time to adjust to the new drugs, and also the effectiveness or efficacy has yet to be seen, and therefore he would recommend that I continue with my old medication. And I felt that his advice was sound, and therefore I did not go for the new drug. As far as I'm concerned, the old drug would be more suitable for me. And I've also consulted those who have been on the new drugs, and also these are also the ex-mentally ill, and they felt that the new drugs have been good, and there is also not much side effects, and therefore they believe that using the new drugs would also be very good. That's why when compared to conventional old drugs, the new drugs would be more effective. All in all, I believe that with the new drugs, yes, the efficacy would be more prominent, and also there would be fewer side effects, and therefore that would be good for the mentally ill. That's why I suggest that the HA, when it comes to new cases, they should try to go for the new drugs, and for those who are not able to take the new drugs, they should go for the old drugs. But then I think we should step up our understanding of the drugs, and the HA should also consider enhancing the knowledge of the patient so that they would know how to take the medication, and also the efficacy, and also the side effects and complications or contraindications, so that they would also have greater confidence in taking those medications. Thank you. Thank you, Mr. Wong. Next, Mr. Wong Chun Man, Vice Executive Director from the Hong Kong Association for the Deaf. We have been very concerned about the deaf and also the hearing impaired in terms of the medical and health aid they might need. Therefore, we have been setting up groups to help them to get hearing aid. And when we provide services, we also identify 2 problems. Number 1 is the students who are facing problems. Well, yes, the administration would be offering 2 hearing aids to those in need, but then because of the specifications, not many students have been able to fully develop their potential by using the standardized hearing aid. In fact, many parents would rather buy their own aid, or they would also have to procure their own aid, and that would also put a lot of financial pressure on them, because the administration would not allow the parents to top up in order to get better quality hearing aid. And also the measures that we just set out, well, for those who are over the proper age, they would also not be eligible. For those who have retired, they do not have any income, and therefore they can only rely on the OALA. And many of them would also not apply for CSSA. Yes, they know that they have the need to have to use a hearing aid, but then because of their financial difficulty, they would also not get this aid, and therefore their quality of life would be affected. According to Chinese Youth recent studies, Well, many elders are suffering from depression because of their hearing difficulty or impairment. That's why we should offer assistance to these elders with hearing difficulty so that they can get their hearing aid as soon as possible. The association would like to recommend the following. That is, the Education Bureau should change its current system, and we should issue coupons to these parents so that they would be able to choose the most suitable hearing aid for their children, or they could also top up the fund so that they could get better hearing aid in order to make sure that their children would be able to get what they need. And also the administration should consider expanding the scope of aid for the CCF so that for those who are not on CSSA, who are elders, they could also get some funding for procuring hearing aid. Next, Mr. Kwan from the Rehabilitation Alliance Hong Kong. Well, many disabled and chronically ill have been raising a number of questions about the standard drug formula. Well, for many which have been recognized as effective medication, they have not been included under the specialist list, and there are also no patients' representatives on the board, and therefore the whole thing has been done rather mysteriously, and therefore we hope that the HA can increase the transparency of introducing drugs on the drug formula, and there should also be patients' representatives so that they would be able to join the committee on the standard drug formula. And we also welcome that Samaritan Fund has also relaxed the means test for self-financing drugs. But then for many patients and disabled who are living with their family, they are not able to benefit because the vetting criteria would also take into account the entire family's income. As a result, for patients' family members who are not willing to pay for such medication, then the patients can only give up on the self-financing drug, or they will have to go for leaving their family so that they can live on their own and then get the aid. And the Samaritan Fund would only take into account the patients and also their spouse's income and also assets. On the other hand, in terms of medical and rehabilitation appliances, the eligibility criteria have not been relaxed in the same way as that for medication, and as a result, many people who are in need would not be able to get any assistance at all. We also hope that the Samaritan Fund would not just provide aid for rehabilitation appliances. They could also assist in terms of some consumables like napkins and so on. We can also see that Samaritan Fund, in terms of its publicity and also the vetting process, is rather time-consuming. We hope that the Samaritan Fund can streamline its management so that it can be done by some welfare agencies in the form of outsourcing, so that they could also step up publicity and the whole process could also be compressed. Thank you.
Next, Mr. Ng Siu Koo from Hong Kong Stoma Association. Good afternoon. My name is Ng Siu Koo. We are the first non-profit patient mutual help organization in Hong Kong. We have over 2,000 members. 80% of our members are patients of intestine or bladder cancer, and a small number of members face they need because of different reasons they would need stoma. And stoma refers to artificial holes in the abdomen of patients, and they are used for egestion and urination. Most stomas are permanent. Stomas are invisible. But in in everyday lives, we would need these stomas to help us digest. And this is categorized under the eighth group of persons with disabilities. According to statistics, we have to spend more than $1,000 per month in most cases. We want to be self-reliant, but because of the stomas, we face difficulties in our work. We cannot push our bodies too hard, or we would experience hernia. A lot of employers are concerned with our working capabilities, especially owners of F&B businesses, and sometimes they would ask us to resign. You can see a lot of young patients, they really want to work, but they couldn't find any employment because no one wants to hire them, and hence the economic difficulties. In terms of financial assistance, we hope this meeting can help us. We hope this subcommittee can help us. I won't go into details because they are already written in our paper, so I hope you can take a look. The cost of a stoma packet, it ranges from $10 to under $100. And this is a necessity for us, and we need financial and long-term financial assistance to help us. We recommend the government to launch a medical apparatus coupon. We want to maintain financial stability as well as flexibility. We have to take special care of our stoma because they are very sensitive. Improper handling improper care can lead to inflammation of the skin and other skin problems. I hope you can help us with the concept of coupons. Mr. Yip Wing from the Labour Party. My name's Yip Wing from the Labour Party. The government said they are heavily subsidizing public hospitals, and the percentage of subsidy is 96.8%. But this percentage only covers public hospitals as well as public clinics for people who are not receiving CSSA or for patients who have to pay for their own drugs. This figure could not represent the challenges faced by these people because they are paying for their own treatment. The government said their aim is to promote mutual support among family members and take the responsibility to take care of their family. But I think it's the government who is irresponsible. I have applied for a subsidy and I was rejected. One of the application criteria was we cannot apply for similar subsidies in the past 3 years. For example, the Yan Chai charity fund. But as far as I know, the Yan Chai fund does not receive any assistance from the government. I have to give up the funding for 3 years in return for long-term financial support from the government. The government says they are really taking care of the of patients like us. The charity fund is actually supported by from people outside rather than the government. The government is well positioned financially. The medical subsidy given offered by the government is relatively stable. Equipment such as electric wheelchairs or breathing apparatus, motors, batteries. For 3 years, it comes to over $200,000. Money is a big problem for many families. Our recommendation is for under the table for PWDs, there should be an extra section to be filled in by medical practitioners or doctors to see what kind of equipment support they need. And next, MS Advocation Group, Mr. Yan Chun Kit. Yes, we hear you. In 2005, I suffered a recurrence of sclerosis. I have to visit the hospital 4 or 5 times a month, and I have to pay for doctor, for transportation, and there is a recurrent expense for us. The cost is very high for me. Right now, the medical apparatus is getting more and more expensive, and we don't get any subsidy. What are your criteria for application? I was applying for a high rate, but I was granted a normal rate, and I'm very unhappy about that. Every time I have to argue in order to obtain a higher standard rate for physical disability. I have to use batteries, replace tires for my wheelchair. Is the government trying to split up families instead of helping them? When I want to apply for personal CSSA, you said me and my wife and my children have to apply separately. So why are you forcing us into a corner? You're giving us tremendous mental stress. Even the simple acts of buying something is very challenging for us. I have to take six or seven drugs at the moment, and the cost is substantial. So what help are you offering to us? So I hope you can consider our situation. I'm not trying to be negative, but I just want to tell you how I feel. Sclerosis is getting more and more common in Hong Kong, so I hope you can take this into consideration. Thank you very much. Mr. Lau Wai-ming. Muscle problems. ALS is getting more and more common, and patients need intense caring every day, and they need to use breathing apparatus, and the caring of wounds is also very meticulous. As Mr. Said, they would require 24-hour help, and apart from equipment, they would need a lot of consumables, and this causes tremendous stress to the patients. If you are aware of the news, a person called Edward Hong in Canada was trying to, who is an ALS patient, was seeking anesthesia. And when you look at Hong Kong, when you look at the supports, the safety net offered to most patients, how can these patients be self-reliant? These patients might receive a lot of encouragement, but what kind of concrete support do they receive? Nowadays, a lot of modern equipment like wheelchairs, breathing apparatus, electric beds, they are very helpful, but all these are very, very expensive. Most of our support comes from the CCEF, the Samaritan Fund. But for the Samaritan Fund, applicants are required to apply on a family basis, and our expenses due to disability are not taken into account. So our level of income is actually overestimated. And when rehab apparatus is taken into account, our assets cannot be 3 times over the cost of those equipment. And these conditions are very harsh, and this means that a lot of patients cannot enjoy the assistance. The CCF supports the purchase of consumables like breathing devices. And stoma patients need a lot of consumables, but they are not covered under CCF. Why do patients not receive the same support even though they all have the need? And the application criterion of the family-based application criterion has caused a lot of strain among families. You can, and another point is, if you can give us a lot of advanced equipment, but we don't have the space at home to store these, or in some cases we don't know how to operate these equipment, and the maintenance fee for these equipment is not very affordable for most families as well. Hong Kong Neuromuscular Disease Association Limited, Ms. So Gintana. A lot of neurological patients face a lot of difficulties.
In terms of financial aid, we propose that the Samaritan Fund should allow the disabled to apply on their own or in their own capacity, and the Samaritan Fund should also cover breathalyzers, respirators, and other equipment, and also certain dietary supplement, and also the repair and maintenance aid, and also the retrofitting of their household in order to suit their needs. In fact, for respirators and also relevant medical aids, there aren't that many people who are on the waiting or who are trying to apply for that, and the household's income should be raised to 150% as the criteria for application, and the disabled should also be allowed to apply in their own capacity. And there are also some matching aid just now for the different medical aids and also retrofitting and also the manpower that would be required. We propose that there should be better case management, as can be seen from the paper. Well, there would also be a case management system which will be put up, but then apparently that will be outsourced. We don't think that's the best approach. We think that the administration should take up the responsibility so that they will be able to play the role of a case manager. And for neuromuscular disease sufferers, when they apply for decanting or rehousing, case managers would be better placed to manage their cases. And we propose that under the CCF, there should also be a $2,000 special aid, and yet the age eligibility has not been relaxed because there is no reason why people over the age of 60 would not be eligible unless there are other forms of assistance, but then we cannot find any. And we also suggest that we should make reference to the eligibility criteria for respirator and also consumables for respirators. We should take reference from that. The CCF should also consider for people who might require multiple assistance, if they are able to hire a helper or carer, then that would also be good. So we have already submitted our written submissions. Thank you, Ms. So. Next, we have Mr. Wong K.Y. from the Hong Kong Pioneers Mutual Support Association Limited. Thank you, Chairman. I'm representing the Hong Kong Pioneers Mutual Support Association Limited. We are an integrated mutual aid group for people suffering from multiple cancers, as we have said. We'd like to include more cancer drugs in the drug formula in order to ease the financial pressure on the patients and their families. As we just said, the most important thing is to do away with the means test taking into account the household income. We should allow the patients to apply in their own capacity or on an individual basis. That would help our members, because as you know, for cancer patients these days, when they take targeted cancer drugs, it's very expensive. It's not affordable by the ordinary citizens. That's why for self-financing drugs, even for those who are from the middle class, they would have to sell their flats in order to pay for their medication. If the administration can help them by offering some financial assistance to them, then that would also help ease their pressure. Thank you. Next, we have Ms. Leung Mei Kun from the Christian Oil Heap Fellowship Limited. Thank you. Good afternoon, everyone. The Christian Oil Heap Fellowship Limited is a patient mutual aid group. We have already got 18 groups in all the 18 districts. We have also been doing a lot of education on mental illness. We believe that number one, for the mentally ill, they might be living with their family and they are not able to work, and because of the means test they might not be eligible for CSSA. For them, financial pressure is a very serious problem. In particular, for the aged carers, they are not able to make money, or they are not able to work, and yet they also have to take care of their mentally ill family members, so that would only add to their burden. And also in terms of tax allowance, for the taxpayers, they have some tax allowance, but then for these carers, they do not have any such assistance, and therefore we should try to help them so that they can receive care in the community. Or else, if you just pass the buck on to these elderly carers, then they would suffer a lot. And many of the mentally ill would like to stay in their own units, but then because of their physical problems, they might also suffer from psychiatric problems, and the administration has arranged for them to stay in some private homes, but then they could only offer some meals, but not a lot of mental assistance. So how would they be willing to do so? Hence, we have to ask the administration with regard to rehabilitation and also care for the mentally ill. When they hear that they would be offered a place in the private homes, they would be very scared. And some doctors might think that by referring them to a private home, they would be able to get better care, and they would also be able to stay in the community. But then with an aging population, these ex-mentally ill are also aging. So how can you meet their needs? Finally, is about the lack of drugs. I don't know if it's a problem with the pharmacy or the problem with doctors. Sometimes they would be dispensed with fewer drugs, and sometimes they will have to go to the hospital and on another day to get the medication. But then for the aged patients, that would be very difficult if they have to go there again. We hope that they could also have recycling box to recover some of the medication which has gone beyond their shelf life. Next, we have the Hong Kong Cancer Fund Cancer Link Support Center, Tin Shui Wai, Ms. Chow. We were set up in 1987. We are the largest rehabilitation group for cancer patients, and we focus on helping those families with cancer patients. Well, as we all know, with an aging population, there are more and more people who have suffered from cancer. In 2011, we have over 26,000 patients of cancer, and our experience is that, well, for those who are already midterm or terminally ill, that would be very difficult to treat. But then with advancement in technology, many of these patients can be treated, including taking some targeted cancer drugs. Well, this should have been encouraging, and yet many of these drugs are very expensive. They are beyond the affordability of most families. For example, well, we have Calvic, which is for leukemia patients, and the minimum cost would be up to $18,000 a month. Well, even for lung cancer patients, if they take such drugs, the minimum cost would be about $15,000 or above every month. And a few months ago, I heard from a patient telling me that the doctor has recommended another drug, and we are talking about some $50,000 a month. So how can an average family afford that kind of cost? Yes, you have the safety net under the government system. Yes, we have the CCF and also the Samaritan Fund. But then for people who are working and for patients living with their family, they are not eligible for those assistances. And according to our experience, many of the cases that we have will have to take out loans, or they will have to sell off their property, and they have been forced to do so in order to afford the drugs. And for some patients, they can only give up their jobs, and in some cases they might even have to consider divorce in order to be eligible for the Samaritan Fund. And in some cases there have been a lot of family disputes. I don't think that's something that the public or the administration would like to see, and therefore the Cancer Fund would like the administration to be concerned about this. And for this purpose, we have also got several recommendations. Number one, we hope to increase or improve the operation of the Samaritan Fund and also the CCF. We hope that on a regular basis you can review the situation so that some of the restrictions can be relaxed. Well, under the Samaritan Fund, well, in terms of the rise in costs for certain medication, when compared to the rise in wages, the pace has exceeded that for our wage increase, and therefore we should review the asset limit and also the income limit for the applicants, and there should also be a regular review of the drug formula. The most important thing is the scope of drugs to be covered. Well, if you look at the drugs that are eligible for the coverage, well, that has gone beyond the actual use of such medication by hospitals. Well, they are just sponsoring some second-line drugs, but then the doctors are already recommending first-line drugs. And as many patients have said, the eligibility should be relaxed so that it can apply on an individual basis instead of having to apply on a household basis. Thank you. Thank you, Ms. Chow. Next, we have Ms. Leung Ka-yi from the Hong Kong Bone Marrow Transplant Patients Association. Yes, our association is a rehabilitation group for bone marrow transplant patients. It's a complicated operation, and it takes a lot of resources in order to conduct this operation, and both before and after the transplant, many patients would need a lot of medication, and they would also have to undergo a lot of tests. As many patients have talked about the drug support issue, we are also concerned about this. We also hope that the CCF can relax its vetting criteria in order to facilitate the application, and in terms of the number of drugs to be covered, that should also be expanded. Well, for many from the middle class, well, you might call them middle class, so long as you have a flat in your hands, then many applicants would no longer be eligible. So that would also affect those patients who need treatment, because that would render them not eligible for such assistance. We have also got a patient. Well, his family has this HOS flat. Well, her husband is a taxi driver, and because his wife is sick, therefore she has to be on this target cancer drug, and he is not able to afford it. And as a result, some hospitals might have to adopt this approach. That is, 3 patients will be sharing 2 medications. So they will have to pair up with CSSA recipients, because most CSSA patients would be eligible for that, and they can also pair up with civil servants, because they would also be eligible for free medication. And sometimes they will have to wait till some patient can be on that medication. So 3 patients will be sharing 2 packages of medication. So they can only wait till the chance has come, so that another patient might come up, because for a dose of medication it might cost some $9,000. But then sometimes they might not get an adequate dose. So in other words, they might not be able to get a full dose. They can only share it with another patient. So can an alternative be considered? All right, if they are living with their family, of course the patient will not be able to work since they are sick, but then their family members might also be working. So in terms of a tax allowance, can you allow the patient's family to get a higher tax allowance? If you have a family member who is chronically ill, then can you get a higher allowance? It's like getting parents or dependent parents allowance. Also, under a public system, you have to ensure that is adequately staffed. Earlier on, the Queen Mary Hospital's bone marrow transplant center has expanded so that more wards and patient beds can be included. We hope that for leukemia beds or wards, a corresponding number of beds can also be increased, so that there are more patients who have undergone bone marrow transplant. They can also have extended care. And also for daycare beds, there should also be an increase, because there might be complications, there might be resistance and so on. If they have problems when they go back to the hospital, they do not have to go into the general ward, because in the general ward they are more prone to infections. Well, for bone marrow transplant patients, as their immunity is lowered, and therefore they will have to have vaccination on a regular basis, and recently they've also got some vaccination for shingles. So for the general outpatient clinic doctors, sometimes they do not dare to give such vaccination to the patients, and therefore very often they will have to go back to the hospitals to have such injections, and that would also add to the pressure of the public sector hospitals. So we believe that if we can allow them to go to some clinics where they can have the vaccination in their community, that would also be that would also be better. So can there be vouchers so that they can go to their nearby district to take the injections? And if it's issued by the hospitals, then that could also show that the patients are suited for such vaccinations, so that they can just go to an ordinary GOPDs, and then the doctors will be able to say that the patients can get the vaccinations as recommended. And also for dental care, well, after the bone marrow transplant, well, as some patients groups have said, well, dental care Very often, for some patients, because of their chronic illness, their dental health would be adversely affected, and therefore they would need better dental care. We hope that the administration can take care of that.
Finally, the University of Hong Kong South Pole Center of Aging, Dr. Donald Wong Kempun. I will try to summarize what others have said so far. I want to talk about the policy. The administration is trying to maintain prudent finance. There was a report published by OECD in 2003. It's called Transforming Disability into Ability. And the idea is that the level of assistance should not be linked to the family, the economic situation of the family. When we look at the CCF and the Samaritan Fund, the government's thinking is that we don't have a lot of money, so out of these limited resources, we can only do our best, and that means the able individuals should pay more. For medical assistance for PWDs, the aim is to help them lead a life or go to work. We should encourage them to help other PWDs, and the government has not considered the social impacts of these PWDs. Right now, the existing policy doesn't encourage PWDs to work because it's very hard for them to find long-term employment. Right now, there are three disadvantages for the current policy. First, it's very hard for PWDs to find a job, and even if they manage to do so, upward mobility is very limited. And second, it's very hard to obtain disability allowance. And if their family members have high income, in effect, we are punishing those family members. Mathematically, you might not be classified as poor, and in such scenarios, you don't get anything. You might have saved some money with the Samaritan Fund or CCF, but in return, on the other hand, people might go and apply for CSSA impact. So at the end, you couldn't save any money. The government said they want to encourage family members to help each other, but in reality, they are splitting up families. I hope the government can think more broadly. I hope the government can read the OECD report, which was compiled by 34 countries running market economies. Hong Kong's definition and understanding of PWDs is actually very far behind global standards. We have to deeply understand their needs. The core aim should be to help these PWDs overcome their disabilities, and relevant training must be conducted. However, this strand of thinking doesn't seem to be incorporated in the current policy. When we look at other countries like UK or the OECD platform, they have an arena to look at issues related to PWDs. the thinking behind our policy should not be just to save money. We should establish a multi-policy platform to safeguard PWDs under the UN treaty. And this way, we can allow Hong Kong to be a comfortable home for PWDs. And for the middle class who pay a lot of taxes, they are not able to enjoy medical and rehab services promised to PWDs. Let's invite the administration to respond. The deputations have mentioned several issues. First, different types of cash allowances. For instance, Samaritan Fund, CCF, CSSA, all these subsidy under under the unit of families, and these funds are in fact dividing up families. Middle-class families might be happy to take care of their families, but because of the medical expenses, they might become the so-called poor middle class. And second, for all these funds, the Samaritan Fund, CCF, CSSA, we have a lot of comments on the subsidy of equipment. First, Miss Lee from the FEHD, from the FHB. Thank you for inviting us, and I want to outline our support policy currently. Under the current policy, Hong Kong citizens enjoy a lot of subsidy from the government. Over 90% of the drugs on the standard drugs formulary costs way less than their original costs. For patients who require drugs outside of the standard formulary, the HA is trying to offer support through the Samaritan Fund. Some deputations said they voiced concerns over the transparency of the operation of the Samaritan Fund and the standard list, and a lot of patients are not aware of the operation of the inner working of the fund. And the HA has heard the opinion, and they have done a lot of things. They have considered drugs which should be incorporated into the standard list. And for existing drugs on the formulary, would they need to be reviewed? We understand that the concerns is which drugs should go into the standard formulary. Hopefully, we can incorporate this list in HA's website to provide more information for patients. And we would include this on the agenda for the next meeting so that we can collect more comments from HA members. So to understand the needs of patients, there is room for improvement in terms of transparency, but this is an area we are working very hard on. On the Samaritan Fund, some patients are concerned with the scope of coverage and the tests and the vetting process is quite strict. We are reviewing the application requirements. Right now, the application units are families, as you may know. And this is an existing policy of the government when it comes to safety net and public money. We are continuing to review the financial means tests of the Samaritan Fund. As you may remember, the principle of using family as the unit of application, we would review the policy to see if there's any room for improvement. In 2005, we have introduced certain exemptions. We understand that most families have some savings. If you exclude all these savings, it might not be very fair. So that's the reason we introduced certain deductibles in the application procedures. So under this existing framework, we would introduce more deductible items as such to try in order to help more patients. DHA will continue to review the overall procedure of application. And for the drugs, the maximum patient contribution has been reduced from 30% to 20%, and we're hoping that more patients can benefit. What else? Psychiatric drugs. Can you focus on the updates? You are just repeating what was already covered on the in the papers. Do you have any updates in response to the deputations? Some people are concerned with the use of new drugs. The HA has adopted a lot of new drugs. I can give some figures for psychiatric drugs. Since 2009-10, 35,000 patients use new drugs. And for 2013-14, 55,000 patients are using new drugs. And for antidepressant drugs, the figure rose from 70,000 to over 100,000 patients. We will continue to review our practice. In the 2014-15 budget, a sum of 32 million has been reserved in the budget to expand the list of drugs for psychiatric and elderly patients. In the application of the Samaritan Fund, some middle-class families might not be eligible because they own a property. I just want to remind you that if you have a self-owned property, you can deduct the value from your from the total income. One of the deputations mentioned something about 3 patients using 2 portions of drugs. Why? Do you know why that happened?
How come 2 patients, or how come 3 patients will have to share the medication that is intended for 2? Would like to call upon patients not to do that, because the prescription is made by the doctors, and if they have any financial difficulty, please do contact us. We'll see what we can do to help. Mr. Sui? Yes, thank you. Chairman, I'd like to once again thank the deputations for their very good comments, both in terms of the policy rationale and also the operation of the CCF and also the disability allowance run by the administration. You've given us a lot of valuable comments and concerns. Indeed, that will also help us roll out some future programs and policies. Well, as we know, generally speaking, for people with financial difficulty, if they are caught by the CSA net, then generally speaking, that could also help to meet the needs of the patients and the chronically ill. But the thing is, how can they be caught by the CSSA safety net? Well, for people who are outside the CSSA and they are not very well off, and they would tend to have greater difficulty. And for people who need instant or consistent care, then they might not be taken care of. And we are also not able to take care of groups with special needs. As we heard, some people might need respirators. And also in terms of medical consumables, the cost might be pretty high. So these are the groups that would need further assistance. That's why under the CCF, we have been introducing this program to target those who are seriously chronically ill and also those with physical disabilities. Well, just now I heard some deputations say that there are some problems with some of these programs and there is room for improvement, as we have set out in a policy address. With regard to respirators and also medical consumables, well, they would be made regular programs, and we expect that by the end of this year we'll roll out those regular programs. But then before then, we would be making use of the time before the formal implementation of those programs. We'd like to listen to the stakeholders' views so that we can discuss that with the disabled groups, so that in terms of the details of the operation, for example, for consumables, what is the scope of coverage, and also if there are other recommendations, we will have an open mind in listening to your suggestions. With regard to taking care of the disabled, we believe that it's not just about financial assistance. We also hope and need a better community care and support system. That's why, as we have said, we'd like to enhance the case management system so that for the enhanced home help scheme, we would turn that into a regular program, and we would also be introducing an element of case management so that for the high disability allowance and also the consumables, other than making them regular programs, we would also be introducing this case management model. And at the district support center, we will also be increasing resources for them so that they would also be introducing this case management model. It's not just about financial support. We hope that through this new form of management, in terms of the services, they can also be reintegrated so that we will be better able to serve the needs of the patients. As Dr. Wu has said, well, very often I would exchange views with her, and her views are rather enlightening. We hope that the potential of the disabled should be fully developed so that they can integrate into society. So it's not just about giving them welfare or giving them support. That's why we talk about community care and vocational training. We also encourage the disabled to go back to our community. But of course, a lot of efforts will be required. And in our policies, we need to fine-tune them in order to suit their needs. And I'm grateful to Dr. Wu. And some patients groups also talk about hearing aid, including the quality of hearing aid for the students. But just last week, I already received this submission, and I've already passed it on to the Education Bureau. We hope that we can follow up on that. With regard to elderly's hearing aid, I understand that the Samaritan Fund and other funds can also offer assistance. So much for the time being, and I'll be responding to further comments later. Just before I open the floor to members and groups, well, one point was made by the deputation, and I think the Commissioner has also got an important role to play for the disability allowance. Well, for a student staying in a boarding school of a school, then instead of getting the higher disability allowance, he'll only be getting the ordinary allowance. But then they might need certain consumables. And to pay for such consumables, they might need to get the higher disability allowance. So their need is still there. But then because they are staying in the boarding school or in the hostel of the school, they would no longer be eligible. So that's against the original intention of the CCF. So will you reconsider this arrangement? Thank you, Chairman, for reminding me of that. Indeed, we have taken this up with the SWD. Well, yes, they might only be eligible for the ordinary DA, but then since 1988, we introduced the higher disability allowance. That's precisely to help those who are not staying in subvented homes, and they also need special care. So there should be no qualms about that if they are staying in residential care homes or in boarding school. And for students staying in boarding schools, they would also have to go back to their homes during holidays. So they will still need to be taken care of. We'll talk to the SWD to see how things can be improved. Well, yes, there is always some room for improvement, so we'll leave that to the SWD. But then I've heard that, and Mr. Lee also mentioned that if they stay in a hospital, they can only stay up to 30 days. From their perspective, all right, that has already been relaxed. So it doesn't mean that the assistance will stop from day one, but then after they've stayed in the hospital for 30 days, such assistance will be suspended. So there is room for improvement. And also on the eligibility for CCF, you will have to look into that. If there is no relaxation, all right, the applicant is now on ODA, but then if you look at the actual physical condition, they should be eligible for the HDA. Yes, we'll be looking into that too. All right, 5 minutes each for members. I'll read out the names. Leung Yiu Chong, Lam Kwok Hong, Poon Siu Ping, Joseph Lee. First, Leung Yiu Chong. Thank you, Chairman. I'd like to give some time to the deputation who said that, well, 3 patients can only get 2 portions of medication. So he didn't have enough time, so I'll give him some time to elaborate on that. Well, the administration has been emphasizing this, all right. The long-standing policy is that no patient would be denied proper care because of the lack of means. So that's the rationale behind your policy. But then the problem is, well, when it comes to financial difficulty, how is that defined? Well, as we have heard from many deputations and some patients' representatives have said, the problem is that when it comes to financial difficulty, they are not eligible for any medication support. So I don't think I need to repeat those cases. So they are experiencing tremendous difficulty. So what I'm trying to say is I'm not going to go into the details of each and every case. For example, for the stoma patients, they have given us this submission setting out their difficulties. So I just want to talk about the overriding policy or principle. You said that you will be reviewing the drug formula on a regular basis and in a timely manner. So by doing it in a timely manner, you will have to note that sometimes patients cannot afford to wait till your next review because to them, every day they are faced with this difficulty. In particular, for the cancer patients, if there is a delay by a day of treatment, then the condition would get worse. And the chance of them getting cured would be slimmer. Yes, even if you review the situation once every 3 months, that might still be too long an interval for them. So can you be more flexible in dealing with these applications? Because for the marginally eligible patient, well, you would deny or reject their application if they are marginally above the threshold. Can you be more flexible in dealing with such cases instead of being so rigid? Because to many, that might offer a lot of help. So that's the first point that I'd like to make. So in dealing with such cases, can you be more flexible instead of adopting a straitjacket approach? Second, when it comes to different forms of assistance, there might be duplication. So can you allow them to get different forms of assistance through different channels, because under different schemes there might be different coverage. But then very often you would say, no, there cannot be any duplication. If you have applied for one, you are not eligible for another one. Well, it's like disability allowance and also other forms of support. All right, by getting the DA, you should already get some form of assistance. But then for the elders, if they need other consumables, then they cannot use the DA for that. And then for the younger people, if they are not eligible for certain assistance, then they would not be able to procure certain medical or rehabilitation aid. So the most important thing is, can the criteria be relaxed so that for the marginally eligible, can they get more assistance? All right, you said that you would give some time to the deputations, bone marrow transplant patient. Well, for 3 patients sharing 2 portions of drugs, we are not talking about medication. We are talking about drips. So it's not shared amongst the patients by themselves. It's done by the hospitals, because sometimes for the target drugs, they would have to be prescribed in accordance with the body weight of the patient. But then once the ejections have been prescribed, they cannot be used for a second time. They will have to be used on the same day. So there are indeed situations whereby several patients will be sharing one portion of medication. So there were patients who needed to go back to the hospital to get the drips, and then for the extra or the surplus medication that could be used by another patient. And then there might be patients who might be going back for the drips at the same time. So the hospital would prescribe or administer the drug on the same day. Well, in some cases, they might need more frequent drips, but then they might have to wait till another patient has to get back or go back to the hospital for treatment before they can also go back. In other words, the doctors and the nurses are fully aware of that. Yes, they know that some patients will need that, and they fully understand the situation. That's why they try to accommodate that. Well, this is really news to me. This is quite a shock. Our healthcare system has deteriorated to such a situation whereby a patient is so worse off, and therefore he will have to use the surplus medication not used by another patient, and that's done under our medical system. Well, it's not that he's so worse off that he cannot afford it. He's from a middle-class family, but then because her husband is a taxi driver, all right, it's difficult for her to apply for CSSA or other forms of financial assistance, and she has already stopped work because for some bone marrow transplant patient during the first year, they cannot go out to work and they cannot come into contact with many things. And just now we were talking about a bone marrow transplant patient. Well, he has a tumor in his bone marrow. So even after she has received treatment, if there should be a relapse, then she would have to be on target drugs. And for one dose, that could cost her $8,000, $9,000. And therefore, for every cycle of medication, well, either she will have to raise funds on her own, she will have to get up to $100,000 in order to spend that on one cycle of medication, or the nurse could also help her. If several patients can group together, then they will be able to use the medication together.
I don't know if this is your current policy. I hope you don't, after listening to what Ms. Leung said, you won't stop this patient from the chance of receiving these medication. I agree with what Mr. Leung Yu-chung said. I agree with the system of case management by HA. We should allow some leeway. Nonetheless, as an advanced society, if there are patients in Hong Kong who need to only use drugs left over by another patient. I'm speechless. This is very, very sad and shameful. I think the government must face this issue. Apologies to Mr. Leung Yiu-chung. I think this case is shocking, and the government should certainly respond. But I hope you don't try to suppress patients like this. As Ms. Leung said, the situation is unsatisfactory, for sure. If you can share more information with us so we can know about his situation. Is it because of his past employment as a taxi driver, or is he facing other difficulties? We'd like to know more in order to help him. So feel free to pass on any extra information. Mr. Leung Kwok-hung. What I heard is rather bizarre. If they have to apply as a family, they can just divorce. The treatment, one treatment cycle costs $100,000. Perhaps the doctors or nurses, out of goodwill, they offer to give the leftover drugs to that patient. So who are you actually punishing? It's a sin to ignore your family members. That person, if you ignore your family members, you would be punished at least by your own conscience. But in this case, the patient is the one suffering. If a patient is being ignored by his or her family members, and the government is not aware, who are you really punishing? You are not. So what is? Who are you actually punishing under this system? Is there an objective in your policy, or are you only thinking about money? And this should be the aim of the government. If you are saying that you are being responsible by being financially prudent only, if your husband or wife doesn't care about you, what are you going to do? And if you run out of money, what are you going to do? Are you going to go and come to me and ask for help? You are not paying attention to the lives, to the patients. You're only looking at money. You're only thinking about money. I have mentioned this issue a lot of times. The crux of the problem is that this practice is not sustainable, but you have to convince the people of Hong Kong. If you allow individual application, how much more money would you need to spend? You have to come up with a number. Second, recently the FS said we have run out of money, and so virtually we are stopping the funding. During the review process, we have a lot of unsatisfactory cases. How much does John Chang know? I hope he can come and listen to these cases. what is he doing? Maybe he's just hanging out with the bankers. Please invite him to a meeting like this and let him understand the pleas of the victims and patients. You have set so many rules, and you have come up with this mechanism of CCF, Samaritan Fund. We are talking about patients, and they are often very unsettled. They're already, the situation is already very bad, and they still have to beg for help from you. Do you feel shameful? You have to come up with a figure. How much money do you need to spend? You have to help these unsettled people. You are only paying attention to our infrastructure, and you are ignoring welfare services. So let me repeat again. John Chang should really come and see what the middle class and the grassroots are doing. He said he's part of the middle class, and he has caused a lot of misunderstanding. So a lot of people who are poor might think that they are actually from the middle class. Is he sick or something? If so, please give him a drug or something. I think the members don't have time for coffee or French movies. French movies are not just about romance. Some of them are very sad. Some of them are about war. So the movies the FS watch aren't the same movies we watch. He only watches romantic movies. There are a lot of movies about the plight of poor people in the society. So we will relay your message to the FS. So thank you very much for all the comments. On the medical financial assistance on medications and medical appliances, a lot of people find them inadequate. The government said we have CSSA, Samaritan Fund, CCF, etc. There are different kinds of assistance. What I want to know is, Dr. Wong gave her view on the current policy, and that is the able has to pay more, and it's built on financial prudence. Does the government agree with Dr. Wong's view? If so, if there is going to be an assistant director, will this policy be reviewed? And the Stoma Association suggested the idea of vouchers for medical equipment. I don't know how much it will cost, but will the government consider this proposal? Two questions. First, do you agree with financial prudence and able pays more? And second is vouchers for medical equipment. I agree with Dr. Wong's proposal. Our policy is to provide financial assistance as well as community support and employment support. The aim is to maximize the capability of PWDs and allow them to become assets of the society. And that's the overriding theme of our policy. That's the overriding goal. So we don't just look at financial support, but we also consider community support. We would regularize certain support services in the society and enhance support centers for PWDs in different districts, so that the infrastructure can match the financial assistance in terms of employment, help. Last year, we launched a policy in which if the employer employs a PWD, if the employer needs to purchase special equipment, they can receive a maximum subsidy of $20,000. Nevertheless, any policy must be sustainable. We have to gauge the overall financial position. Our aim is to allocate the resources to the people most in need. And we have heard the comments of the members and deputations. And the vouchers for medical equipment, will you say something about that? For medical equipment, for people with severe disabilities, apart from the respirators, we will also subsidize the purchase of consumables. We have heard a lot of people who want to expand the scope of consumables. So in our regularization measures, we would like to hear views on what consumables should cover, be it diapers or maintenance fees. We would consider incorporating them into the scheme. And on the subsidy amounts, should we have any adjustments? We are open on all these fronts. A deputation mentioned milk powder, personal care services, etc. Would you incorporate these? We will remain open, and again, the main aim we want to take care of patients with special needs, especially people with severe disabilities under the disability allowance. We want to support these patients and help them integrate into the society. We will continue to listen to opinion. We might have subsidy under other schemes, and that's why we adopt this approach of case management. We would mobilize different social resources to help these PWDs. Can you clarify on the point of consumables for people with severe disabilities? The existing requirement is that the patient must not have received any similar subsidy in the past 3 years from other organizations. For example, the Yan Chai Fund. So this requirement is rather bizarre. So is that the case? I don't have information on hand, but we will certainly review this area when we carry out regularization measures. If this requirement does exist, you must cancel it. Joseph Lee. I'm concerned about the issue of 3 patients sharing 2 doses of drugs. I'm in this industry, so it's not surprising for me. Do you mean that the 3 patients have to chip in and share the doses of 2 patients, or is it that some patients would consume leftover drugs by another patient? So in that case, they don't have to pay anything. So is it the case of using leftover drugs? Or are you systematically dividing up the drugs of 2 patients?
So I don't know how that's done. Well, in terms of the actual operation, for those of us at the front line, of course, we would use the cheapest dose. Well, assuming that I'm joking. Okay, so if it's done in the form of leftover. So, well, for doctors and nurses, we know how to administer the drugs, even if you want to have leftovers. Well, sometimes it's not appropriate. So, supposedly the patient might need that once a week, but then if he has to wait for 3 months for the dose of drug to be shared, then that might not be good. So we have to find out the facts. That's point number one. That's very important, and that will also give rise to this situation that is about the target drugs. So I'd like to put this to the administration. All right, the overriding principle is that no patient should be denied proper care because of the lack of means. But then for target drugs, so would that be regarded as appropriate care? So for these patients, if they are denied target drugs, then they would not be getting proper care. So according to the administration, you may not be able to answer that question. Well, other than target drugs, there are other forms of treatment. But then for the other treatments, there might be more side effects, and the patients might suffer more. Because as far as I'm concerned, the current situation is if they do not have access to target drugs, then their condition cannot be treated. Or if I'm from a middle class, you are asking me to spend every dollar and cent that I have before I would be eligible for any financial support. So that might give rise to a lot of misunderstanding. So the administration might as well take the opportunity to clarify the situation. Yes, Ms. Lee? Thank you. On the inquiry about target drugs, I'll defer to Ms. Chong. Yes, in simple terms, not all target drugs would be dealt with across the board, requiring the patient to pay for them. It depends. If they are already, some of them have already been included in the standard drug formula, or if they have been tested to a certain extent, they would also be placed under the safety net of the Samaritan Fund. Some are still under trial. That's why they would only be covered by the CCF. So basically, those are the broad categorization. So it doesn't mean that so long as it's a target drug, then the patient will have to pay for it. No, I'm not talking about procuring them on their own. If it's a necessary treatment, if it's for financial reason that you're not supporting that, then that's not right. But then if it's not necessary, then whether or not the administration is going to sponsor that, that's another thing. Well, it depends on whether or not there are other replacement drugs, and if there are other replacement drugs, and if the doctor, after seeing the patient, knows that there are alternatives, then of course the doctor might wish to prescribe other treatment or other medication. In other words, they will still receive proper care. So it depends on the merits of the case. All right. How about the sharing of medication? Ms. Leung, or who else can answer the question? Because indeed that's a matter of concern. All right, because of this sharing. So if it's treated like leftover, and if the treatment efficacy might change or might be affected as a result, then this is a very serious matter. Well, in the case that I have, you cannot just call that a leftover or leftover drug. It sounds appalling. Well, let's say if they need 100 units, let's say the dose is 100 units, well, the patient would need 100 units per person, but then some might have a heavier body weight, then the dosage might vary. So the case that I just referred to, so it's not the 3 patients themselves sharing the dose. So 2 patients might be eligible for that for free. So what I'm saying is that for CSSA patient or CSSA recipient and civil servant recipients or civil servants, they would be eligible for that medication for free. So I might have exposed something that I should not have talked about. Well, the nurse might be aware of this. All right. We are not suggesting that you can only have that injection after 3 months. Well, they might need to have frequent injections. Let's say they might need that once every 10 days. And then in the end, they can only do so once every 10 days or once every 20 days. So they will have to wait till the dose is available. So it's not like leftover. They are not using drugs that have not been used by other patients. So the situation is about hospitals sharing the drugs among different patients, because some of the medication cannot be kept after it's been used. So sometimes 3 doses might be good enough for 5 patients. So indeed, if there is surplus medication, then if that patient can benefit. Another situation is because of the financial position of a particular patient. All right, on the issue of target drugs, do they really need those target drugs? Well, I just refer to a particular illness. All right, they will have to catch up with new drugs because for the old drugs, they are already becoming drug resistant, and therefore they will have to turn to some new drugs. But then some of these new drugs might not be covered by the safety net or on the drug formulary. That's why they will have to pay a higher cost for that. So if you ask, do they need the new target drugs? Because they can only survive with the new target drugs. Of course, only the doctor can tell, because it depends on the nature of the medication, and their cancer index might have gone up, and therefore they can only control the condition with new target drugs. And the patient that I just referred to, he has already passed away. Well, just one word. All right, in any circumstance, whether or not you're measuring the dose by the weight or by the body weight of the patient is appropriate. So in terms of the dosage is appropriate, but then when it comes to the resources, you will have to make sure that the treatment efficacy is there. That's okay. But then instead of having 1 dose every week, if you can only have 1 dose every 2 weeks, then that would also affect the efficacy. And if still the doctor and nurse would recommend that, then I would have question marks about this. And also for patients sharing the cost, well, it's very commonplace at the front line because you're making better use of the medication. But then if the treatment efficacy is affected, then that's not tolerated. That's not tolerable. We can trust the professionalism of our healthcare professionals in terms of the administration of drugs. If that affects the conditions of patients, then I'm sure they would not resort to those practices. But then I think we are talking about some kind-hearted healthcare professionals, because the affordability of the patient is in question. That's why they would try to arrange for some surplus medication to be used by them. So the doctor and the nurse are aware of that. But then once again, we'd like to emphasize, we cannot emphasize enough, that is, the administration must not suppress them. This is something that we have to really look into and think about. Yes, Deputy Chairman. Thank you, Chairman. I'm not a professional either. So we are all concerned about the sharing of medication and also the keeping of such medication and so on. I hope that after the meeting, the deputations can furnish us with further details if they don't want to expose the details of the case here at a public meeting. But then we have heard many deputations, more than 10 deputations are here, and they talk about medication and consumables and so on. Well, for the 4-page document supplied by the administration, it has failed to address many of these concerns. I remember at the welfare panel meeting, we talk about the residential care homes. Well, your colleagues have been working very hard to come up with these residential care places, and they said that well, money is not the problem, but then finding the right location is a problem. But then here is easier. So we don't need any site. We don't need that many people. All we need is money. So given the fact that it's under the same policy bureau, there should not have been different considerations. All right. One of the concerns is about the review of the DA, the disability allowance. Here we are not talking about $1,200 or $1,500 and the eligibility for those allowances. So what kind of assessment do they have to undergo? But then the most important thing is to provide better support, both in terms of medication, medical or rehabilitation, aid and so on, as many deputations have said. So how do you define the disabled when it comes to eligibility? How come you are calculating that, or you're carrying out the means test on a family basis instead of the individual basis? So what we're most concerned about, at the end of the day, you're just concerned about the amount rather than the whole system. Well, we have spent 2 hours meeting with government officials, and we have told you our actual needs. So some time has elapsed, and now they have once again set out their needs at an open meeting. So are you going to review and reform the system in order to meet their needs? What's the timetable for that? Second, well, on the Samaritan Fund, I think even for legal aid, you would only be counting the spouse's income together. So how come you are looking at the entire family's income? So when are you going to review that? Mr. Soy? Yes, on DA's review, let me emphasize again, as I just said, the disability allowance is only providing some form of financial support and is to support the disabled to reintegrate into society so that they can fully develop their potential. That's why I'd like to emphasize that for the DA, we have to make sure that it's targeted at the right place. It's not just about their financial ability. We also have to look at the community support and also other forms of support that are made available to the disabled. As I just said, well, at the same time, while we conduct the review on the DA, we have been doing many other things. For example, community care, including the enhanced home help service. So that would be made a regular program. And on the other hand, we are also looking at those. Well, for the disability allowance, there is no means test at all. So however hard we try it, it's still a very general scheme. But then some also talk about their specific needs. For example, they might need respirators and so on. Well, Commissioner, whatever you say, you're only emphasizing your ability to repeat what's been said already. So for the DA's review or reform, so would you be introducing a multi-layer system so that instead of getting 1,000 or so every month, if they have any specific needs for consumables and so on, then there is no need for further means test, then they can also get the necessary assistance. Can that be done? Thank you, Deputy Chairman. At this present stage, we do not rule out any possibilities because at this present stage, we have already engaged a consultant, that is the Hong Kong U, and we are coming up with a consultancy report. We are looking at overseas practice. And when we look at overseas practices, we would not just be looking at disability allowance itself. We would also be looking at other forms of support. Or even for financial support, there might also be a whole package of support. So we have an open mind. We will be looking at what overseas jurisdictions have been doing before we come up with our own recommendations. All right. If you just talk about vocational services or reintegrating into society services and so on, well, at best, you're trying to restore their ability to integrate into society before they become or became ill. So you're just offering some services to them. Well, we would not think those are genuine reforms and so on. You said that you would not be ruling out any possibilities. But then what's the timetable? And what concrete things are you going to do to help them? I believe that the services would not be superficial. So we have to make sure that the services can meet their needs. And that's point number one. And number two, as we reported earlier, in terms of the review on the disability allowance, by the end of this year, we'll be completing that and we'll be reporting to this council on the development. End of this year.
Many deputations, including the Cancer Fund and other deputations, they recommended that the Samaritan Fund be reviewed regularly. And they mentioned that the fund itself is run by HA. And what kind of drugs are included in the drug formulary? Some of them are not incorporated into the Samaritan Fund, but basically the HA controls everything. There is a certain degree of transparency. But all the meetings are behind closed doors and participation is limited. Can we have at least one public consultation session every year on the eligibility and coverage of the Samaritan Fund. Right now, we cannot have any direct involvement. Can Ms. Chung respond on the review of the Samaritan Fund? Thank you, Chairman. On the drugs coverage of the Samaritan Fund, we are continuing to improve communication with patients as well as promotion efforts. Every year we meet with patient committees. We have at least 2 major meetings every year. And we would outline the new items under the fund as well as new drugs under the fund. We will also listen to their comments on the new drugs or new drugs and recommendations. We have at least 2 such meetings every year. We would consider doing more on communication and so that the patients can know more about our application procedures and eligibility. After so many years, if you have 2 meetings a year, after so many years, the deputations still have the same questions and concerns. You just have to look at the cases in which families are split up because of conflicts over the application, and also issues such as the cost of medical apparatus. You do not take the needs of people with severe disabilities into account when you grant the standard rates. Some patients might need more than 1 carer. These patients are really struggling. In some cases, the drugs are really expensive too, and they are being driven to the poor end of the society. Obviously, the existing mechanism is a failure. Does an independent review have to be carried out in order to introduce new thoughts? Right now, the annual meetings with the patients might not be the most effective approach. On the means test arrangements, we have improved in the last few years. In 2008, in the means tests, we have taken into account unemployed patients, and we would not consider any income from these people. And for patients who have academic expenses or recurrent medical expenses, they are deducted. These expenditures are deducted. We have also introduced last year the idea of deductible expenditures, and those modifications were made after listening to comments from patients. And for non-drug items, we have taken care of medical equipment or one-time medical apparatus and consumables. These are not covered. These consumables are not currently covered. For example, bandages, milk powder. These items have been covered under other schemes already, so it's not covered under the Samaritan Fund. The aim of our fund, the main goal, is to help the patients who are leaving hospital with their daily needs, such as wheelchairs. we will help upgrade or repair any malfunctioning equipment. We understand that you have made improvements, but today we have heard a lot of concerns after so many years. And I hope you can conduct a thorough review. These meetings, these 2 meetings every year, are basically just briefing sessions to introduce new measures. They are not very effective. Ideally, these committees should include patient representatives. Mr. Leung Ko-hong, the second round of questions. 3 minutes. There's room for reform. If a patient is suffering from serious illness, the society should take care of him or her. This should be our goal when we think about any possible reform. And in other cases, the carers are sacrificing themselves in order to take care of their family members. They might be taking care of their family members or close friends. The living standards of those carers must be dropping during those 3 years, and you cannot wait for them to become beggars before giving them subsidy. So please understand this point. So that's why I ask, what is the objective of your policy? Some people are asking for vouchers for upgrades in equipment. But the situation now is that all of them cannot benefit from from what you give them. So there is a need for reform. And second, we have to look after the carers as well. If you set a line, if you draw a line that's as long as you're surviving, we are not going to offer any help. We must have a clear objective in our policy. That's a basic principle of governance, and that's ethics. We have to think about our impacts on other people. What do we give? What can we give back to the general public? Right now, you are coming up with these policies behind closed doors, with so-called financial prudence. You just have to put yourself into the shoes of the patients. I don't see how it's so difficult. You should not break up families. The patients are very unfortunate to be suffering. It's something beyond their control. They are not to be blamed for being lazy or something. It's something inevitable. As I said, can you ask John Chang and C.Y. Leung to carry a stoma? And if they do so and they say they are happy with it, then I'll be happy. Just a small stoma will do. They have to disinfect regularly. Yeah, if they can do it, I'm happy to do it as well. So can John Chang and this HA representative to carry a stoma without any help? If they carry a stoma and they're still happy with the existing policy, then I have nothing more to say. Any response from Mr. Siu or Ms. Lee? Putting yourself in others' shoes will certainly help the patients. And that's why we spend so much public money every year, because we want to maintain the high level of assistance. I hope more people can benefit under the Samaritan Fund, and we'll try to be lenient in terms of eligibility, and ideally we can incorporate the self-finance drugs into the formulary. We will tackle the problem from different angles. Very simply speaking, can you come up with a charter? I'm not talking about legislation. Can you come up with a charter saying, stating your policy objective and schedule, etc.? If you have such a charter, if I come back to 5 years later, we can follow up with the progress. Fernando, you can come up with new products. So you can come up with new products for people to invest in. Let's say I'm taking out an insurance package for my mother. For an ordinary wage earner, he or she might take out an insurance package. Would you invent this kind of product or insurance package? Without real democracy, I think it's very hard to ask for the government to put themselves in other people's shoes. I'm not talking about democracy here. You cannot count on the kindness of the leader. We have to rely on ourselves to safeguard the welfare of the people. The government has made it clear in their policy, and they said no one will receive inadequate care because of inappropriate policies. We have heard a lot of stories today from patients. We know what the government said was a lie. Nevertheless, the government holds the power. We can only use the Legislative platform for different people to voice out their opinion, and we hope the government can listen. When you read the news every day, you see people urging, almost begging philanthropists to give them money to buy certain equipment. When you think about Hong Kong as an advanced economic society, this is really this is a real mismatch. Right now, patients can only apply on a family basis. This is really regretful. So I hope the government can review certain issues after today. The principle is please don't split up families. Please allow individual applications. I hope you can reflect these comments to the Bureau. And for the eligibility of different funds, I was surprised. I was quite surprised.
And also for patients sharing the medication, I was also surprised. So you will have to go back and see what kind of discretionary power should be given in order to make sure that things are done properly. All right, you said that you'll be reviewing the Samaritan Fund, and also you would also be introducing the revised drop formulary. But then I also hope that there can be a consultation exercise, because just now, as some deputations have said, with regard to the case management system, they also have different views. So, so much for today's meeting. Next meeting, we'll discuss the guardian system for people who are mentally incapacitated. All right, meeting is adjourned. Thank you.